So my presentation is titled Pain Without Stain. As we all know, ocular pain is classically of two varieties, nociceptive pain and neuropathic pain. Nociceptive pain is pain in which it's a physiological response to any noxious stimulus, be it inflammation, trauma or infection. Neuropathic pain is, however, the variety in which the pain persists even after removal of the initiating insult. So consider this case example of a 30-year-old male patient who came to us with severe ocular pain and discomfort. The dry eye evaluation was almost within normal limits. However, the ocular surface disease index indicated severe disability, the score being 54. So the signs and symptoms did not show any correlation. The tear film metrics cannot explain the patient's disproportionately high pain and discomfort. So what is the missing link in such cases? So the research question that we asked was, what is the cause of disproportionately high pain in patients of evaporative dry eye? So our research methodology included detailed dry eye evaluation followed by in vivo confocal microscopy. Patients' symptoms were also graded using the Ocular Surface Disease Index questionnaire. Systemic evaluation included analysis of serum vitamin D. So the OSDI questionnaire is a validated questionnaire for grading disability in patients of dry eye. We divided this 12 subset questionnaire into discomfort subscales and vision subscales. So this is how we analyzed the images on confocal microscopy of the subbasal nerve plexus using a special CC metric software. What you can see in blue is the nerve branches, in green are the branch points, and the red denotes the main nerve fibers. This is just a representative photograph. On your left you can see well delineated cell bodies of immature dendritic cells, and on the right is mature dendritic cells with typical dendritiform processes. So pre-treatment, as you all can see, there are a lot of dendritic cells, and the patient obviously had a lot of pain and his OSDI scores were high. We put the patient on anti-inflammatory treatment, after which his symptoms relieved. The dendritic cells are visibly low in the second photograph, and the patient's OSDI score also dropped, and the patient was symptomatically much better. So we published this article which establishes a correlation in the subbasal nerve plexus findings, ocular surface disease index and vitamin D in patients of evaporative dry eye. So a lot of you might want to ask why vitamin D. This is because vitamin D has been shown to be associated with dry eye, and its role as an anti-inflammatory agent, especially regulating dendritic cell function, has been established. We analyzed the tear samples taken from these patients of atypical dry eye, and we found that there was a relative imbalance between the pro-nociceptive and anti-nociceptive factors which explained symptoms of pain and discomfort. Moving on to vitamin B12 after vitamin D, this was another patient who did not respond to conventional intensive topical therapy. When the patient came to us, we incidentally diagnosed a serum vitamin B12 deficiency. Patient was then put on parenteral treatment of vitamin B12 injections, and within 3 weeks of treatment, patient showed dramatic improvement in symptoms. So this is another vitamin that you have to keep in mind when managing such cases. This was a patient whose symptoms were so persistent, and repeated dry eye evaluation at multiple places failed to determine the cause, and the patient's symptoms were blamed actually on psychiatric illness. When the patient came to us, we saw that the dendritic cells were impinging onto the nerves as seen on confocal microscopy. Hyperreflective terminal nerve bulbs were seen on confocal microscopy, and when the cornea was imaged using a handheld high-resolution OCT, we determined, we saw a break in the Bowman's membrane. So the hypothesis...
Can you summarize, Kalyani?
Yes, sir. So the hypothesis is that the tear film inflammation actually permeates into the stroma through these breaks and invites dendritic cells, which increases the inflammation, and the release of stromal proteolytic enzymes helps stromal proteolytic enzymes increases the breaks and propagates the vicious cycle. So the take-home message here is that understanding ocular pain is very important in managing this complex phenomenon of pain without stain. Imaging and cellular biology helps us understand and treat ocular pain better. Treat the cause, such as determine the vitamin deficiency and not just the patient symptoms using multiple lubricants. Thank you very much.
Thank you, Kalyani. I don't think we have time for the question. Karishma, if you can just do a fast forward thing of your small presentation.
Thank you. I'm going to be talking about a completely new aspect, a new axis. We're correlating migraine with dry eye. I have no financial disclosures, and I would like to thank my team at Narayan Netralaya and my mentor, Dr. Rohit Shetty. It was one of his novel ideas that came up with this, and thank you for letting me present over here. So we all know that everything under the sun, including the sun itself, could be a trigger for migraine. Now we are trying to look at something new, possibly optical aberrations as a trigger for migraine. So let me just start with a slight basic of aberrations. We're talking about the OPD3, which is the optical path difference 3 scanner. It gives us a breakup of aberrations into total, corneal and lenticular aberrations. And it also gives each aberration, each structure's breakup into total, higher order, tilt, coma, trefoil, etc. It also gives us a different display which can give us the PSF, which is the point spread function, and the modular transfer function, which gives us an assessment of the visual quality of the patient's vision. So what has already been proved in a paper by Martin Mainster is that glare can trigger nociceptive pathways, which itself can lead to a headache. So we are trying to go one step behind and show why is this glare coming. Is it because of optical aberrations that are causing scattering of light? So the aims of our study were to see whether optical aberrations were a precipitating factor for migraine. Where did we get these patients from? These were the patients that walked into our OPD complaining of a headache. They were further sent to a neurologist for confirming the diagnosis of a migraine. And what we know is that light triggers migraine. What we're trying to prove is whether aberrations produce the migraine. So 60 patient eyes versus 60 control eyes were studied in statistically insignificant different legal groups. And our inclusion criteria, the most important inclusion criteria we looked at was that the spherical equivalent was less than plus or minus 0.75, because we didn't want those with a large refractive error to come with symptoms of pain, etc. In our methodology, we started with the basic dry eye workup, which was Schirmer's, a tear film breakup time. Then we subjected the patient to a LipiView interferometer. We studied their objective scatter index on the OCAS system. And then finally, we studied the aberrations using the mesopic wavefront on the optical path difference 3 scan. So all these patients, when they arrived in our OPD, were first subject to this questionnaire. This is a migraine screening questionnaire from the British Medical Journal of Neurology. And a score of 3 or more would be considered as migraine positive on this screening questionnaire. So if they were screened positive, they were further sent to the neurologist. In our results, we saw that the LipiView was significantly different in patient eyes versus control eyes, as was the objective scatter index. The tear film breakup time didn't really differ in the two groups. But what is more interesting is that all the aberrations that were analyzed, which is the total, the higher order, the coma, and the spherical aberrations, were significantly high in the patient eyes as compared to controls. So
can you summarize, please?
I'm done. So our hypothesis is that a dysfunctional tear film probably leads to high aberrations, which causes increased scatter, which probably is the trigger for our migraine. And if we are possibly able to treat this dysfunctional tear film with some sort of lubricating agents, then we might be able to reduce that glare and help alleviate their symptoms. And that's about it. We need to study a larger population, of course. Thank you very much.
Thank you very much. And before we conclude,